Good afternoon. My name is Liz Deers. I'm Senior Vice President and Chief Legislative Counsel for the Medical Society State of New York. I'd like to welcome each of you to MSSNY's Advocacy Matters program. Advocacy Matters is a one-hour continuing medical education webinar series that is held on the second Tuesday of each month. This initiative is sponsored by MSSNY's Legislative and Physician Advocacy Committee. The Advocacy Matters series is designed to enhance communication with physicians across the state concerning issues of significance to physicians and their patients. Elected officials, agency officials, and key legislative and agency staff have been invited to discuss regulatory and legislative issues. Today's webinar will provide each participant with 1 hour of CME credit and will go from 12:30 to 1:30. At the end of the program, you will be asked to complete a CME evaluation of today's speakers. The evaluation will be posted at the end of the webinar for each participant to complete. Your CME certificate will be emailed to each of you within the month. You will be muted for the didactic part of this presentation. Save your questions for the Q&A period at the end of the program. To ask a question, you may either raise the hand located in the box to the right of the PowerPoint or send us a question via the chat. For CME accreditation purposes, let me state that I have no financial interest in any portion of today's program. Our presenters, Don Buziak and Joe Finch, have disclosed that they are employees of Imprivata. The program today is entitled Two-Factor Authentication. What is it? How is it accomplished? How can it facilitate electronic prescription of controlled substances? We are fortunate to be joined today by Don Buziak, State Vice President, Product Marketing at Imprivata, and Joe Finch, Inside Sales Engineer at Imprivata. Imprivata is a healthcare IT security company that provides authentication, access management, and secure communication solutions. We welcome you to our program. We have over 80 physicians who are registered for today. Don and Joe, please proceed with your presentation.
Thank you so much, and thank you, everybody. We're certainly very excited to be presenting here. Thank you for your time. So from an agenda perspective, we will talk a little bit about why EPCS matters, and we'll go into a regulatory overview, and then we'll do some demo, and then obviously, as Liz just described, open it up for a Q&A. So, let's talk a little bit about why security prescribing of controlled substances and why now. Obviously, there's the New York iStop legislation, but I think there's some backdrop as to why that matters and why it's important. If you look at the left-hand side of this slide, what we see is really an unbelievable trend of controlled substance abuse across the country. You always hear about in the news, in the New York Times, et cetera, there's, deaths of famous actors, et cetera, that are heroin and cocaine overdoses. But when you look at the trend, you see that deaths involving drug overdoses from prescription drugs or controlled substance abuse is actually more than 2 times that of cocaine and heroin combined. So there's really what we see as a national epidemic around prescription drug abuse. And so that's really driving, I think, at the state and federal legislation level, EPCS legislation such as iStop, and we're seeing similar legislation now being starting to be put in place in Massachusetts and Minnesota and California and other states as well. If you look at the right-hand side of this slide, now I think Joe and I have talked to many hospitals, clinicians, prescribers, and what we're seeing is really 4 trends that I think are really important to talk about, and we'll go into these in more detail in the subsequent slides. The first is this concept of controlled substance prescriptions dramatically increasing, and why is that? And we'll talk about this more, but what we're seeing is over the course of the last couple of years, controlled substance prescriptions have increased from 10 to 30% in terms of the overall number of prescriptions that prescribers issue. It's a huge trend. So we're seeing, obviously an impact to the prescriber workflows, clinical workflows, et cetera, as a result of this increase in prescriptions. Now that's then driving this concept of dual workflows, which I think is causing provider and patient dissatisfaction from everyone we've talked to. I'll talk about this in more detail, but this is the scenario when a patient gets a dual workflow scenario. So think like a Lipitor prescription and an OxyContin prescription, right? One is controlled substance and one isn't. How do you handle that workflow? Do you push them both to paper? Do you give one a paper prescription and one an electronic prescription, et cetera? And so we're seeing this causing a tremendous amount of clinical workflow frustration, patient dissatisfaction, et cetera. And then from a healthcare prescription or healthcare system level, we see this concept of meaningful use, and everybody's obviously very familiar with this, but because there's meaningful use legislation around e-prescribing, if you think about this concept of controlled substances and the amount of controlled substance prescriptions dramatically going up, what's happening is in order to make your meaningful use to e-prescribing limits, it becomes a challenge if you don't include e-prescribing of controlled substances. And then finally, obviously, we'll talk briefly about the iStop legislation. I think that everybody's pretty familiar with that. So if we go into more detail here, what we're seeing is this, that controlled substance prescriptions have dramatically increased from 10 to 30% over the last 5 years. And part of this is this tipping point of Vicodin moving to Schedule II. So now all of a sudden, one of the most prescribed controlled substances in the country is moved to a controlled substance. So what's happening is this concept of everybody saying, all right, either I need to prescribe something else or I need to follow the EPCS legislation in order to prescribe Vicodin. So I think, and you can obviously look at the reclassification controls that are put in here, but from a clinical workflow perspective, this is causing a ton of challenges where, patients are saying, hey, I need this prescription, and then it needs to follow into an EPCS limitation. How do I handle that? Now all of a sudden patients are coming back because there's no refills. Patients are coming back to the clinician over and over again. I think what it's causing is this huge trend and driver to implement EPCS solutions. I think this is an interesting topic, the dual workflow topic. Now, there's been a ton of studies on this that show really, as you can see from the slide, about 40% of the prescriptions that are issued are non-controlled. About 20% are purely controlled substances, and about 40%, as you can see from the middle of the graphic on the left, about 40% of the prescriptions that are issued are a mix of controlled and non-controlled substances, right? This is that Lipitor OxyContin example. Now, what happens in this scenario often is either a prescriber says, okay, I will default everything to a paper prescription, and now you've got some challenges obviously in New York State with the impending legislation, or they say, okay, I'm going to do a mix of a paper prescription and an electronic prescription, et cetera. But that causes a lot of patient pain where the patient's confused. Why did I get a paper prescription? Why did I get an electronic prescription, et cetera? So I think what we've seen is study after study show frustration from a clinician perspective over the fact of having to deal with dual workflows, and frustration from a patient perspective, again, of having to understand, well, why is this paper, why is this electronic, et cetera. And so one of the big drivers we've seen for EPCS is the fact that it simplifies and creates one workflow, one electronic workflow that everybody can follow. And we've seen a huge uptick where EPCS has been implemented, a huge uptick in patient satisfaction as a result. So you can see some of the items here on the bottom right. As we just described, you see an increase in provider productivity, increase in patient satisfaction. And then finally, I think from a healthcare system perspective, from a financial perspective, what you see is making it easier to meet your meaningful use stage 2 criteria. And I'll talk about this on the next slide. So, if you look at Methodist Hospital in New York State as an example, or Health East in Minnesota, to give you two non-New York examples where they've implemented EPCS, they saw a huge uptick in their ability to meet the e-prescribing meaningful use limits as a result of implementing EPCS. And it's because of the reasons we just described in the prior chart, right? You've got this concept of a huge uptick in prescribing controlled substances, and so less and less can be pushed to paper. And so in order to meet your meaningful use limits, you really have to move towards an EPCS solution in order to do it. So I view this in New York State, where there's legislation, obviously I view this as a scenario where it's kind of a bonus from a clinical perspective. I would recommend that you look at EPCS and say, okay, once this is implemented, I'm going to look to see this drive and increase my ability to meet meaningful use limits. Now, obviously, I think everybody on this call is very familiar with iStop. I know Liz has done a great job educating everybody on this topic as an example. The original legislation was slated to go into effect on March 27th of this year. I think everybody's fairly aware that there is a bill that's currently sitting on Governor Cuomo's desk to move this approval out a year. So the actual date would move out to 2016. Personally, I'm in favor of doing this. I think we need to allow people to have the time to be ready from a technology perspective. But I think what's interesting, especially for folks who happen to work at healthcare systems that might have a hospital or a clinic outside of New York State, is there are several other states that are following, that are looked to be soon to follow New York State, and New York State's a great example with this iStop legislation. In Massachusetts, as an example, Governor Baker has made it one of his first top priorities to do in his current time as the governor. So I'd look to Massachusetts to follow suit shortly after New York State. If you look at some of the other states, Minnesota, California, Michigan, et cetera, they are looking at similar legislation. So I think this is a case where New York has really been a front runner and done an amazing job driving the legislation. Many other states are following suit. What I think we've seen is that many of the EMRs, what this has done is drive readiness at the EMR level. And so many of the EMRs are now obviously making a big push to be technically ready to meet that iStop legislation, as well as the pharmacies. Many of the national chains, CVS, Target, Walgreens, et cetera, now state that they're EPCS ready. So I think this is a case where, New York State has really driven the legislation that I think will soon follow across the rest of the country. Very much a job by New York State. I think the key, though, is really how do we make sure that from a clinical perspective, everyone's ready. And I think this is a case where from a technology vendor perspective, we have to work with the EMRs jointly to make sure that they are prepared and ready to do implementations to make this easy from a implementation perspective. Now, one of the interesting statistics, and this joke obviously has some this slide obviously has some somewhat humorous graphics, but I think this is a really interesting statistic, and I think about this from a clinical perspective, that 1 in 10 clinicians, 1 in 10 physicians have reported that their DEA number has been stolen. So that's reported. My guess is that number's probably a little bit higher than that. It's kind of a scary statistic, right? If you think about this, if you have your DEA number stolen, what happens then is, you can be audited. You can have your DEA number suspended until that audit is completed. You could conceivably lose your license if you're found to have given away your DEA number inappropriately. So a huge kind of repercussions to this fact that 1 out of 10 physicians have had their DEA number stolen. Now this, to me, is one of those big clinical drivers for EPCS in that when you're making a controlled substance prescription on a piece of paper, your DEA number is exposed. And that is one of the biggest ways that this DEA number theft occurs, right? By electronically prescribing controlled substances, what happens is your DEA number is now essentially hidden within the technology and it's no longer exposed to theft. And so this is, I think, from a clinical perspective, one of the huge benefits to EPCS is that your DEA number is no longer exposed and that you're not at risk or subject, certainly minimized, to having your DEA number stolen. Let's talk a little bit, if you remember the agenda, let's talk a little bit about the requirements for EPCS, and then I want to show some of our functionality. So requirements for EPCS, I think this is so important to know. There's, you think about electronic prescribing of controlled substances, and many times you just focus on the EMR functionality. Does my EMR have this module, et cetera? But in reality, there's a lot more to the overall legislation, both at the federal level as well as the state level. I'm going to walk through this in some detail, if that's okay. If you look at the upper left, As part of the requirements for EPCS, everyone must be credentialed, right? So are identity proofed, if you will. And so from a hospital or healthcare system perspective, you have to make this decision. Am I going to go with an institutional identity proofing methodology, which requires you to have a institutional DEA number, or am I going to go with an individual methodology and leverage a vendor like a Symantec or a Verizon, et cetera, which in order to be individually identity proofed? That process would require you to, essentially it's like doing a credit check. You go online with a vendor, again, like a Symantec, et cetera. You fill out your paperwork. You essentially provide background as to who you are, and then that allows you to be individually credentialed. So this is a kind of a key step one in the requirements for EPCS, is you have to be identity proofed, and that's got to be done either at the individual or institutional level. Now, if you move over to the upper right-hand side of this, part of that identity proofing process is that you're assigning appropriate levels of access, who can prescribe what drugs, at what times, et cetera. So that's part of your identity proofing process, again, whether that's institutional or identity or individual. Now, if you move to the middle left, this is when you get into the transaction. So let's assume you've been identity proofed, you've been enrolled in some sort of an EPCS system. When you're prescribing a controlled substance, you must have two factors of identification. Again, this is per DEA federal and state legislation. Now, this is something you have, something that you know, or something you are. This could be, as we'll show in some product demo a little bit later where we walk through your workflows. This could be your fingerprint. This could be a token, this could be your password, but it's got to be two of those three, and that has to be done at time of prescribing. So this isn't a case where, historically with paper prescriptions, you could stack up, all of your prescriptions for the day and just kind of sign through all of them. That isn't really the case anymore, so it's done at a transactional level. Now, if you move to the middle right, once you have signed that prescription, no changes are allowed. So, you've issued the prescription, you've sent it out. It's not like you can do a recall and do an update. It would really require you to issue a second prescription in that scenario. Now, if you look at the bottom left, once that prescription has been transmitted, you can see it cannot be printed for the patient. Now, this is critical, and actually it's been, from what I've seen, a kind of a confusion point in that people will ask for a paper version, patients will ask for a paper version, but again, this is actually a state and federal violation. So the only scenarios when you can, or some of the only scenarios when you can actually print it off is if there was a power outage, that type of thing, and so then you'd be able to print it out. Otherwise, once the point is to keep everything electronic, and part of this is to keep your DEA number safe. And then finally, in the bottom right, is this concept of an audit trail. And this is so if you get audited, you have to have reports that show that you've done your identity proofing, that it shows who prescribed what to whom, where, et cetera. So really an audit trail in New York State, that's up to 5 years, or that is 5 years plus audit trail, to make sure that everybody is matching the legislation. And then finally, just 1 second on this slide, and then we'll jump into the demo, just to give you a little background on who we are in terms of we've got over 1,000 healthcare organizations as customers and 3 million care providers plus. So I wanted to just walk through the workflows in more detail, and obviously talk a bit as we're going through those workflows as to the implication to the clinician. I think, it's critical, while Joe gets ready to share his desktop, I think it's critical in this case to really think about the clinical experience. It's very, very important that, when EPCS solutions are implemented, it's not just done to do the legislation, but to make a doctor or a nurse's life easier, right? So I think that's critical. We'll walk through that as part of the demo. Joe.
All right, great. Thanks a lot, Don. So again, thanks everyone for taking the time to listen to our presentation. So we'd just like to give an example here of how those multi-factor workflows that Don spoke through in the previous slide work in a kind of a hypothetical EMR application that we've got set up here. So I'm just going to log in. I previously entered in my credentials. I'm going to log into our sample EMR. And so this, again, keep in mind this isn't a real EMR. It's a demo. What we're looking at here is one of those hypothetical situations where we've got a controlled substance as well as other non-controlled substances. They're being prescribed to a particular patient. And the idea here is that this is being done electronically, and what we're attempting to show is how we can break down those multi-stage workflows where historically this Percocet might have to be written on paper or printed on a security printer, that kind of thing. Here, what we're going to do is enforce that two-factor authentication, enabling the entire order to go out seamlessly as an electronic prescription of the controlled and non-controlled substances. So now we've got a couple of ways that's possible. So, and Don touched a little bit on this earlier on during the presentation. So we've got a couple of different options here. The first one that we'll focus on is that which is typically most common is the token-based workflow. So many vendors out there are offering one-time password devices, and really that workflow isn't terrible, and it's wide-ranging and certainly available to most, if not all, physicians, no matter where they're performing these authentication steps from. But it's cumbersome. So just as an example here, I'm going to enter in my one-time password, and I will submit that, and then, whoops, I fat-fingered the password. So I've got to go back, look at my token again, maybe pull it up on my smartphone, and I get it right the second time. And so now I've successfully submitted something I have, performing the first step of that two-factor authentication. And next, something I know. And in this case, we have to enter in a password, and this in this case is our Active Directory password. So once I submit those two pieces successfully, we can see that order has been signed in place and sent electronically.
Yeah, I mean, just a couple things to highlight here. I think obviously Joe's in the EMR. He's going through, you can imagine this scenario where you've got a patient next to you and you're prescribing, in this case, Lipitor and Percocet, et cetera. I think, as Joe just described, what you have to be thinking about with these two factors is it's the clinical workflow. When do you want to be using tokens? When don't you want to be using tokens? If you prescribe from home, as an example, you need that token solution as part of the overall process. But if you're in a high prescribing area, do you want to be using that token as part of your workflow? I think it's so important that the clinical experience is done right here to make EPCS effective.
Exactly. Thanks, Tom. And so in keeping with that line of thought where tokens, while certainly very ubiquitous, offered by many different vendors, certainly aren't the best solution for all workflow scenarios. So here, in this instance, we've configured a fingerprint reader as opposed to using that one-time password token device. So in this case, what I can actually do is simply scan my previous old fingerprint, one of many. I can have up to 10 fingerprints, and you can see that was accepted by the system. And again, enter that second factor of a password in and submit that. And assuming that I've done both of those things correctly, again, the order is signed in place. So just an example of an alternative workflow using biometrics. And at this time, those are really the only two validated, DEA-validated means by which a provider can authenticate themselves for the purposes of electronic prescribing of controlled substances. We aren't allowed to use things like proximity badges or, perhaps some sort of a phone-based authentication. They really need to be fairly high security, FIPS-certified authentication modalities, such as fingerprint reader or one-time password tokens.
Yeah, I mean, I think that's exactly right. That's part of, I think, what you have to think about when you're implementing an EPCS solution, right? As Joe just described, it's if you're going with fingerprint readers, they have to be FIPS compliant. Some of the things that you might use today in the hospital, such as a proximity card, are not allowed. So really the options are, smart card, fingerprint reader, or token, as Joe just described. So I think from a best practices perspective, as you're doing your implementation, you have to be thinking about the clinical workflow, what makes sense to use where, when do you want to have fingerprint readers, when do you want to have tokens. You have to think about the hardware that you have, Are all the fingerprint readers that you have FIPS compliant, et cetera? If you want to go down the path of individual identity proofing, do you have a vendor who allows that? If you want to go down the path of institutional identity proofing, then, will you be able to institutionally identity proof all of your clinicians? Is that an enrollment fair where you do that? Is that if you've got multiple clinics, somebody going out to those clinics to do the identity proofing or credentialing process, et cetera? So there's certainly a lot of different kind of variables you have to think of as part of the process.
Exactly. Great. Thanks very much, Don. And then while he was speaking, I was just going to run through that one more time for those of you who may have missed it the first time. So again, scanning the finger, entering a password, and the order is successfully placed. So that concludes the end user portion of the demo. So I'm going to kick it back over to the slide deck, and we can, I believe, take some questions depending on what the participants would like.
Yeah.
So this is Liz. Thank you both very much for both the slide set and your demonstration. Can you help me understand, there are a number of physician practice-based physicians on the phone, and very often they're affiliated with multiple hospitals. What is the process both for ID proofing from a private practice doc perspective and the key fob token versus biometric? It is feasible, I assume, that a private practice-based physician is going to have multiple tokens, multiple opportunities for ID proofing, or can that be streamlined?
Yeah, it's a gregreat question.
Yeah, so I can address that, Liz. So unfortunately, due to the nature of the, I guess, the environment faced by those physicians where they are affiliated with multiple institutions, in most cases, and there can be exceptions to this, but in most cases, they would be looking at having to enroll in each facility's desired, authentication modality, whether that is some form of a token or if they could use fingerprint or something like that. It is really up to the individual facility. But unfortunately today, there's really no one methodology to, say, identity proof a single physician, and that identity proofing follows that physician between different facilities which they may be affiliated with.
Yeah, so I mean, that's exactly right. So if you're affiliated with Mount Sinai Hospital and with Southampton Hospital, that requires you to go through that process twice, and as Joe just described, potentially have two different sets of tokens, one for each facility.
Okay, and I don't mean to ask all the questions here. Let me, again, for accreditation purposes, state that I have no financial interest in today's program, and that our presenters, Don Buziak and Joe Finch, have disclosed that they are employees of Imprivata. So for those who are participating in the program, now is the time for you to ask your questions. You may either raise the hand located in the box to the right of the PowerPoint or send us a question via the chat. And until you do so, I will be happy to follow up with Don and Joe with regard to this. I've heard from physicians that that are private practice, in private practice, and who have affiliations at multiple hospitals. They have one EHR, and that might be the same EHR that one of their hospitals has, but a different hospital uses a different EHR. Is there a seamless flow between EHR technology that would enable the e-scribing to occur?
Yeah, it's a really good question. So if you're, again, let's take that scenario that I mentioned. If you're affiliated with Mount Sinai using Epic and you're affiliated with Southampton Hospital using Siemens, can you your prescribing information flow seamlessly between those EMRs? It's a great question. The short answer is, unfortunately, at this time, no. I mean, everything's kind of self-contained within the EMR and that healthcare system. So if you make a prescription to Joe Finch while you're at Mount Sinai and then you see him again at Southampton Hospital, unfortunately that prescription and that prescription information doesn't carry over as part of the EMRs. Now there is a concept of a PMP database at the state level, which is a required check. So as a clinician, prior to doing your prescribing, you should be checking the PMP database to validate that Joe isn't doctor shopping in this scenario. But that's not done at the EMR level. That's done at the state PMP database level.
Great. Nancy Adams, we're going to open your line. Nancy Adams is an executive director for Monroe County Medical Society. Nancy, you have a question?
Thank you, Liz. Yeah, I'm just wondering, many of our physicians have begun to e-prescribe, and some of them are reporting that the prescription, they hit send and the prescription's ending up in some sort of queue. It doesn't actually go through, and then they have to re-enter the entire prescription to get it to go. It's a little bit of frustration. It certainly isn't a widespread problem, but I'm just wondering if either of the presenters have heard of that.
There's a couple spots where there could be issues, right? I mean, as a general statement, you hit send in your prescription and it goes through SureScripts, which is kind of the secure transmission to the pharmacy. I know that many of the EMR vendors test kind of the accuracy, how often does this go through, et cetera. And as a general rule, I think from several of the EMRs we work with, the accuracy is something like 99.4%, which would, unfortunately means, to your point, there is a small percentage of prescriptions that don't go through and have to be resent in this scenario.
Yeah, and I mean, from what I've learned over the past 18 months, there is a 98% completion rate that historically SureScripts has had. However, that leaves 2%, a 2% failure rate, and so we are going to have to contend with that, I think, over time. A question has come in: what's the difference between a token and a password?
Sure. So this is Joe Finch. I'm happy to take that. So with the token, specifically what we're referring to is what's known as an OTP, or one-time password device. And this is very similar to those that you may have seen issued in some like banks or whatnot, where the user either pushes a button on a small physical key fob-like device to generate, in this case, a 6-digit random string of numbers. Or it could also be a smartphone app, so installed on iPhone, Android, or BlackBerry device. And so either regardless of the delivery method of that OTP device, the core concept to keep in mind is that it is something that the provider has versus something they know, because there's no way for the provider to predict, or someone else for that matter, what the next number that the device generates would be. When we refer to a password, we're referring to something that the provider knows. So that in the case that we just showed in our example, that would be an Active Directory or possibly an Epic password for authentication. And that would not change every time the provider needs to enter it.
I mean, so just to follow up on Joe's comment, if you're going to go with a token as part of your EPCS solution, you've got the option of having a key fob, as Joe just described, this little thing that you often put on your keychain, et cetera. Or you can have what's called a soft token, which is an app on your smartphone, right? So you've got a couple different options depending on what's most convenient for you.
So questions have come in as to how one would prescribe a controlled substance from their home. What would you recommend in that instance?
What generally happens, so as I think about Joe's demo, right, you're entering in your password or your PIN, and you've got the option of having a biometric like a fingerprint reader or a token, whether that's a soft token on your phone or a hard token. I think the challenge is I don't think it's realistic that everyone's going to have a fingerprint reader at home, right? It's just simply too costly, and it probably doesn't make sense. So I think if you're typically prescribing from home, the workflow that we see over and over again is a combination of your PIN and a token. And again, I think you have to make that decision if you want a hard token or if you prefer to just have that be an app that runs on your phone as a soft token scenario.
And so the soft token, that would provide a code, right, that they would have to enter into their software that would essentially enable them to proceed, correct?
That's exactly right. So if you think about Joe's demo where he entered in a token number, what you would do in that scenario is you've got your phone, you open up the soft token application, and it pops up the code and gives you, a specific amount of time where you have to enter that code. You take that code and you enter that in as part of your authentication process during your prescribing, and away you go.
Great. And how does a physician receive the token? From whom do they receive the token?
So, again, this is Joe. So that differs based on, if we go back to one of the initial slides that Dawn covered in the presentation, the institutional versus individual identity proofing models. So with the institutional model, which does require that the credentialing institution has its own institutional DEA number already assigned to it by the DEA, in the institutional model, those tokens would be distributed to the physicians by the institution itself. So maybe that institution's IT department, maybe the credentialing department, regardless of who's handling it, it would be done within the confines of the institution. In the individual model, for institutions or smaller groups that do not have an institutional DEA number, those tokens would be received directly from the credentialing service provider, or CSP, of which I believe currently, and Dawn, please correct me if I'm wrong in this, there are only 2 that are approved by the DEA as CSPs, and they are Symantec, through their VIP program, and Verizon, I believe, also does provide tokens.
That's correct.
And
so depending on list,
that's usually, isn't that usually part and parcel of the purchase of the e-prescribing software?
Not always. It certainly can be. And it's going to depend really on kind of which vendor you go with. So certainly some of the vendors, offer this as part of the solution, and in other scenarios, you would buy the e-prescribing solution, then you would go and negotiate a contract with Verizon or Symantec. Certainly, I think a recommendation would be to look to have one vendor that provides it all, just to make your life and overall total cost of ownership easier.
Right, and I think that's something that you would and we would recommend, that as physicians are doing their due diligence in examining what software vendor to go with. First, they have to look and to determine if they have a need to e-scribe controlled substances. Certainly, they need a vendor that's going to be able to provide them with the tokens and do the ID proofing. And many vendors who have been certified for, first of all, they have to make sure that their vendor is certified for EPCS, but then secondly, they need to find out what subcontracts those vendors have with ID proofing entities and entities such as Imprivatur, who do the 2-factor authentication for them, and many of them do contract with, companies like Symantec to do ID proofing and companies like Imprivatur to do the 2-factor authentication. So it's all pretty much something that you all or your staff need to drill down on before you make a purchase of e-prescribing software. Dr. McLaughlin, we're going to open your line for your question. Hold on, it'll take a second. Dr. McLaughlin?
Yes, I'm here. Thank you. Good afternoon. My one concern is not having purchased one of these units yet. What do you do? You're transmitting a prescription to a specific pharmacy, but then sometimes we often run into problems that a particular drug you're prescribing is not formulary with the patient's insurance. and then you may, if you've already prescribed it, you've already signed off on it, are you in a problem then?
Yeah, I mean, it's a great question, and this type of thing does come up, right, where you make a prescription to, the CVS on Main Street, and as you just described, there's an issue creating that prescription, or perhaps the patient goes to the wrong pharmacy. They go to the CVS not on Main Street, but on, Albany Street, right? And so that type of thing can happen. In that scenario, really what ends up occurring is either that the prescription itself gets canceled and it has to be retransmitted to a different pharmacy, or in the case where the patient went to the wrong pharmacy, if either you cancel and retransmit a new prescription, or that patient goes to the correct pharmacy. So that is kind of a risk, as you just described. If for whatever reason the prescription is wrong or sent to the wrong spot, then in that scenario you do have to cancel and kind of retransmit the prescription.
Right. I mean, this is something that has been part of our discussions with regard to the e-prescribing delay bill, which I will update you on, but I want to make sure that we get to all of your questions before we do so. Now that we have I think an observation from a participant that SureScripts through her EHR does not allow her to cancel prescriptions electronically. Can you speak to that issue, Joe or Don?
That's an interesting one. I haven't actually heard that one before. So that is something we can follow up, Liz, and we can send you kind of an answer after we work with our contacts at SureScripts. I haven't actually heard of that problem before. So that is an interesting one.
Right. Okay, so as you are formulating your questions, let me just ask a simple one from my end. I now have an iPhone 6 and allows for a biometric, but it doesn't always work, and I always end up having to type in my password anyway. So, or my passcode. So, can you talk to me about the reliability of biometrics now in this world that we now live in with e-prescribing?
Sure, Liz. Yeah. So, and that's a very valid concern, and we hear that a lot, particularly related to the reliability issues that a lot of people have experienced with iPhones. Because that was released in the iPhone 6. So one of the ways that Imprivata has addressed this is we have sourced what are called full field fingerprint readers, and these are different than the iPhone fingerprint readers or perhaps those built-in quote-unquote swipe readers that you may see built into a number of different laptops by any number of manufacturers these days. So really what we're doing is we're taking a much higher resolution snapshot of fingerprint data using these full field readers, and that increases the accuracy of the fingerprint read itself tremendously. And I forget how many decimal points it goes out to, but we in production settings have experienced higher than 99.8%, I believe, first read reliability for e-prescribing. So with the proper hardware, with the proper software, it's pretty much a non-issue. But that having been said, there can sometimes be organizational or personal previous experiences to kind of overcome as a adoption hurdle. So we definitely hear that quite a bit.
So are you finding that more and more EPCS certified EHRs are moving toward biometrics? Are hospitals moving toward biometrics? I mean, what's the range of the field thus far with regard to the use of biometrics?
Yeah, I mean, that's a really good question. So what we're seeing is that there's definitely been an uptick in the use of biometrics. We're seeing that, people, to the question that came up earlier, what should I do if I prescribe from home? What we see is people really thinking through the clinical workflows, right? So this is a case where, what are your high prescribing areas? Who who does a lot of prescriptions, let's make sure that they've got a fingerprint reader, a FIPS-compliant fingerprint reader. But if you're at home, et cetera, then you move to more of a token-based solution. So I think, our recommendation here would be if you're looking to move to kind of clinical convenience and you want to maximize that, then you have to move to a fingerprint reader type solution. But you should really look at where are you doing your high volume prescriptions, and that's kind of where you're going to get the biggest bang for your buck from a fingerprint reader perspective.
Okay. Well, we have a question from a participant who only wants to write a few personal prescriptions a month. None of them controlled medications as an anesthesiologist. All of their regular work is done in a hospital setting. They don't want to write prescriptions for patients to fill outside of that setting. What are they to do, and how much will all of this setup end up costing them? And, if you guys want to take a stab at that.
So in that scenario, Liz, did you say that they are prescribing controlled substances or they're not?
No, they're not from their home.
Okay. But they might be at the when they're in the hospital.
They are in the institution, yes.
Got it.
So in those cases, Liz, realistically, that's something that individual provider really would not be implementing themselves. That would really fall back onto the institution to implement an EPCS solution and issue that prescriber either a token or give them access to a fingerprint or some other biometric system. But if they're not writing in their own practice controlled substances, they should not have to worry about these requirements. The standard e-prescribing requirements that they're likely already following today should be sufficient.
So we're going to open the evaluation poll. Please begin to fill that out as we close down the program. I'm looking to ascertain whether there are any further questions through the chat or phone line. And then I will update you on the legislation that is pending. So we see no further. Okay, we do have. Yes, we will. You may obtain a copy of this presentation. Will be archived on the MISNI WebEx website. And it's actually, I'm being told that that's not correct, but it is going to be archived. Miriam?
cme.misni.org.
Okay, cme.misni.org is where you can access the presentation. cme.misni.org. It will not be immediately available. It will. Can I go back to the question? It will be available by the end of today. Now, how secure are fingerprints, Joe or Don?
Sure. So as I mentioned a little bit earlier on, I think when we were discussing the accuracy, I mentioned the concept of FIPS compliance. That's FIPS. That stands for a Federal Information Protection Standard. And basically, it's a validation and auditing measure that the federal government requires that the vendors of both the software and the hardware adhere to, essentially in order, for them to bid on certain federal contracts and whatnot. And it's a fairly reliable standard that we here at Imprivata have settled upon, and it's also required by the DEA in terms of verifying that there's no way that the information that's being captured by a fingerprint reader and transmitted through our software platform can be intercepted and rerouted for other purposes, nefarious or otherwise. So in general, it's really no greater or no less secure than using a one-time password or, even logging onto an online banking website that's been secured with, SSL or TLS encryption. It's all using the same types of security platforms, and we have full confidence certainly in the security of that fingerprint information as it's being captured and transmitted.
So, and we have a quick question here that's come in. Can the federal government access these prints?
They cannot. This information, in the case of Improbata, is being stored within the institution itself, the institution that has this solution deployed. So no, it's all stored in transit and at rest. It's stored in an encrypted format, and only that institution would have access to it. It's not being uploaded to any form of a cloud or central database that would be accessible by anybody not authorized to do so.
Great, thank you. So let me just, I guess, close down our session, and certainly this might engender additional conversation, questions, et cetera. As you know, we have, MSNY has sought passage of legislation that would put off for a year, as Don mentioned earlier, the implementation of the e-prescribing mandate. And we did so. We worked towards this goal because it became clear to us beginning last summer that many of the EHRs were not yet certified for electronic prescription of controlled substances. Since then, a number of them have been certified. However, there remain some that have significant market share here in New York that are still not certified for EPCS. And so we want to enable both those physicians and the institutions that have these technologies, give them enough time to install, debug, et cetera, those systems once they become available to them. And so that's really what began us with the introduction of the legislation. Since then, however, we found that there are other additional issues around in certain care settings, nursing homes in particular, a historical workflow that is going to be impeded somewhat by the implementation, and details around that need to really be further explored, discussed, and dealt with. We've also, as we've discussed already today, there are some other, I think, patient-sensitive issues that also need to be, I guess, given further dialogue. In particular, the issues that we were talking about here, and they directly relate to the DEA requirements that, prevent a patient from, taking a script or from a e-script from being forwarded to another pharmacy once it's been sent to one pharmacy. In some instances, that pharmacy may not have the particular medication in supply, and so the patient would have to wait or go back to their physician. Also, it does not enable patients, unless they know what they're being prescribed in advance, to shop around for the lowest cost medications. And so we're hopeful. The bill has passed both houses of the state legislature unanimously and was sent to the governor on March 2nd. The governor, through our Constitution, is allowed 10 days before he must take action. That brings us to midnight on March 13th. So we are waiting to hear from the governor as to what they will do. I know that we've spoken with the staff, some of the governor's councils, and they're quite concerned. They don't want to find themselves in the same position that they find themselves this year, which is a legitimate concern. And so they've asked what we will do to further educate physicians around these technologies and around, additional adoption. And so we have transmitted and communicated both all of the education we've done thus far over the past 2.5 years, which is very significant on iStop generally, the PMP, and now with regard to eScribe. We have conducted many webinars such as this to educate the physician community as to all elements of iStop. And we've done that in hand with the Department of Health, representatives from the Bureau of Narcotics Enforcement. We will be continuing those educational programs both through the State Medical Society and then working hand in hand with our County Medical Society colleagues in doing additional forums in order to assure that physicians are ready, should the bill be signed into law, that they are ready to go come March 27th, 2016. So that is the status of where we are. We are waiting, and we are encouraging physicians and patients to send letters into the governor's office through, there's a patient letter and a physician letter on the MSNY website through our Grassroots Action Center. Please avail yourselves of those letters and send the letter into the governor. We would appreciate your advocacy on this very, very important issue. With that being said, are there any further questions on the status of the legislation or with regard to Don and Joe's previous presentation? We want to give you an opportunity to ask your questions now. And in conclusion, we would like to thank Don Buziak and Joe Finch for your time today and helping to elaborate and educate the physician participants as to two-factor authentication and ID proofing, very integral components to electronic prescription of controlled substances.
Thank you very much. We certainly really appreciate your time and really appreciate you giving us the opportunity to speak. Thank you.
Great. Thank you, Joe. Okay, with that being said, this will conclude our program today. Please note that our next program, Advocacy Matters, will be held on April 14th, and we will the topic is FIDA education. And you may pre-register for that program by visiting the MSNYWebEx.com website.